right, guys. Hello, welcome back, and welcome to the start of the Neuro One review. This is all from here on forward going to be repeat information, which hopefully will be kind of a relief for you to just kind of sit back and digest everything we're going to talk about. So, first up on our list per request from your guys' poll at the beginning of the summer is we are going to talk about strokes. The plan kind of for this review unit, the next couple of lectures that we have, talk about cerebellar, we'll talk about basal ganglia, the whole lot, is I'm going to treat the kind of layout the same. So the pre-recorded lectures and the slideshows that you have posted in advance are going to be kind of an intro theme, reviewing kind of the basic who, what, when, where, and why, and then class will be on intervention, with kind of a slight exception that I'll probably be structuring class with a little bit more structure. So a little bit less breakout groups and y'all trying to figure out different treatment ideas and strategies on your own, and me providing a little bit more guidance, just because I'm assuming that where your lack of confidence lies with these diagnoses probably lies a little bit more on the treatment end of things. So I really want to make sure I'm crossing my T's and dotting my I's and getting you to that point that you're looking for. So still kind of same format in terms of this is your intro, class will be interventions, but you'll probably have some more slides and stuff like that from me than usual for class. So just as a heads up on that. I'm not going to have any readings for the rest of the semester. Woo! Wow, you're welcome. You guys already did the readings for these courses or these topics. You guys can always refer back to your O'Sullivan chapters. You can always refer back to any articles that you were assigned prior. I'm going to be kind of covering the big stuff, hitting all the important things on the head, and just know that the resources are there should you need to clarify anything or anything like that. But otherwise, just sit back, take in everything we're going to review, and then hopefully we'll have some fun with the interventions. Cool. Okay, here's some fun statistics for you. These numbers change every year. These are actually even a little outdated. Most of this is from 2018. Stroke is a huge presence in the United States, everywhere too, but United States. Bounces anywhere between third and fifth leading cause of death in the U.S. Very commonly cause of death for with underlying cardiovascular disease. Almost 800,000 people get diagnosed with a stroke every single year. 7.2 million are living in the States today having survived a stroke. And what's really important to know is this last bullet, it's the leading cause of serious long-term disability. So not only is this a hugely present patient population, the implications of this diagnosis for long-term difficulties and impairments on quality of life is pretty significant. And we play a huge role in this patient population across continuum of care in a variety of different ways. So each and every one of you will certainly be dealing with this diagnosis, whether it be a primary diagnosis and their reason for coming into PT, or something you see pop up in their past medical history and they're here for something else. So very, very common. What's really important for your patients who've had a stroke is feeling comfortable with, but also being able to educate them on risk factors. Do not assume that this bit of education has been done by another member of the healthcare team. The reason why this is so important, more so than any other risk factors really that we've talked about, is that the really big thing here is once you've had a stroke, your chances of having another one again doubles. So we have got to figure out why you had this stroke to minimize it happening again. Now, some strokes are totally idiopathic or bad luck, or there was an undiagnosed malformation in the vascular system and there was nothing you could do to prevent it. You were a ticking time bomb, that kind of thing. But the majority of people who have had a stroke have one of these modifiable and or non-modifiable risk factors that they can highlight that pertain to themselves. We like to focus most of our attention on these modifiable ones. Those are modifiable risk factors, are risk factors that we can change or completely eliminate. Non-modifiable, can't do much about that. Still helpful to educate, But obviously, we can't do anything about us getting older or anything else on that list. So this is where we live. And you will see that a lot of these too, actually physical therapy has a direct relationship with in regards to reducing the prevalence, the severity, the progression, everything like that. Diabetes, obesity, physical activity, hypertension, vascular disorders, all of that we can help with. So this is absolutely part of our wheelhouse. And again, do not assume that these conversations have been had. I cannot tell you how often I've had patients who have survived a stroke and I've asked them what their doctor said about why they've had a stroke. First of all, they can't even tell you what a stroke is. Second of all, they have absolutely no idea why it happened to them. They never thought to ask. That might be surprising to you. Us as healthcare professionals, we know the importance of asking questions, of being educated about whatever it is that ails us, and we know how to ask the right questions. We are the exception to the rule. If you've ever been to a doctor's appointment with one of your parents, it can be stressful because you're kind of like, how do you get by without me? Or at least that's how I've always felt. You know, the kind of average Joe and average Jane don't necessarily know how to best advocate and learn about their own health. So this is something we want to make sure we pay attention to, because there's such a direct link for this to happen again if we don't nip it in the butt. And surviving one stroke is hard enough. Surviving multiple strokes is very unlikely without serious disability. Another really interesting thing in terms of risk factors is this very unflattering picture right here. When I say unflattering, I mean it's unflattering to us here in the Southeast. There is a geographical predisposition of stroke prevalence in the Southeast. We in North Carolina are part of what is called the stroke belt. It is a belt of southeastern states that the prevalence is significantly higher than the rest of the country. There are some thoughts as to why. There are some direct correlations. There are some still head scratchers as to why it's so much more prevalent down here. Obesity is higher down in the Southeast. Inappropriate dieting habits, things like that, are all higher down here. Other comorbidities are also higher down here. So that definitely leads into it. But that is not a super great picture to see given where we live. All right. As mentioned, another really surprising thing that I've always found is, and I ran into this a lot when I worked on the stroke floor in a rehab. So now they've had a stroke at least for a week, right? If not more, by the time they get to rehab. Depending on the patient's level of cognitive deficits or none, as well as family. When I ask a patient if they could tell me what a stroke is, they can't. Again, patients don't know how to ask the question. They're just trying to take it all in. They're overwhelmed. This is super scary for them. They don't know. So we need to not assume that this education is being done, and don't be afraid to give this education to your patients. But also it's important for you to feel comfortable with it yourself too. 80 to 90% of strokes are ischemic. And that is represented in this image right now. That is when some kind of foreign body, or in the form of a clot, blocks an artery and stops blood flow, and therefore the oxygen that is in that blood from reaching crucial brain tissue, and that brain tissue ultimately dies. Ischemic is either thrombotic. A thrombus is a blood clot that forms within that artery that ultimately gets impaired. Or embolic. An embolus is a blood clot that forms elsewhere and travels to the brain. An embolus can form a lot of times it'll form in the heart and shoot its way up. Our heart is connected to our brain by just a few arteries. It is a straight shot up, but you can have a DPT in your leg and it can make itself all the way up to the brain. So there's a variety of different kind of preceding things that can happen for an embolic stroke. Then we have hemorrhage, less common, typically has a tendency to be more acutely dangerous. It is more likely to see mortality acutely with a hemorrhagic stroke than ischemic, and that is just because it's uncontrolled bleeding. There's a lot more swelling associated with hemorrhagic strokes, that kind of thing. Hemorrhagic strokes are typically either formed by an aneurysm that blows out the side of a artery, a weakened artery wall, or an arteriovenous malformation. So there's a malformation between that kind of conjoining area where our arteries and our veins meet. It is a high area of vulnerability, and that malformation can eventually blow. AVMs are often we tend to see AVMs in our younger stroke patient population that are otherwise healthy. They had nothing wrong. AVMs do not cause any signs or symptoms until they have ruptured. So it kind of goes from nothing to everything right off the bat. We do tend to see it typically a younger patient population with those AVMs. Then we have TIAs. TIAs are called mini strokes, or more importantly, warning strokes. They're called warning strokes because they are just that. A TIA is a transient stroke. It is a transient narrowing or blockage of an artery in our vein. So this mimics an ischemic event. And then either that narrowing just isn't bad enough that it causes a complete blockage of the blood and it kind of is able to wiggle its way through, or if it is a transient clot, that clot eventually gets pushed through and disintegrates. But a transient TIA is called a warning stroke because if you have a history of a diagnosed TIA, your chances of having a full-blown stroke increase tenfold. Tenfold. It's very much a big, raging red flag of warning to these patients, which is why it's so important to understand those risk factors and help your patient figure out what it is that's causing this incredibly significant warning sign, because they're essentially a ticking time bomb for a full-blown stroke, which will have obviously much more dire implications long term. TIAs tend to last at most 24 hours with regards to their symptoms, and then the patients make a full recovery. But we don't take that for granted because these guys are so commonly precedent to a stroke. Strokes are diagnosed first by clinical examination. There has to be something wrong enough for these folks to walk into the door of either their doctor's office or the emergency room, but ultimately it's going to be diagnosed by radiographic evidence. When we talk about clinical evidence, you see ads all the time, especially during stroke month. But also commercials and this and that about Act Fast, which is a fantastic campaign. It was put together by the American Heart Association and the National Stroke Association to educate the average day American about signs and symptoms and warning signs of stroke. And it's this right here on your slideshow, and it's talking about the symptoms commonly associated with a acute stroke. Facial droop, arm weakness, speech difficulty, and then T is for time. You've got to call 911 right away. The faster you get in for medical management, the better your overall prognosis is. The one thing that gives me reserve, though, about the FAST campaign, even though it's fantastic and any education is better than no education, just forewarn your patients or forewarn your family members that those aren't the only symptoms that cause a stroke. A lot of people won't have any face drooping or speech difficulty or anything like that. They may come in with just the worst headache of their life that they have nothing they've ever experienced. They might come in with altered mental status. They might come in and they've passed out or they're having weird visual changes. It's just like there's so much variety in terms of what neurological symptoms you can see in a stroke. The first symptoms are pretty variable too. That's just something to be aware of. But still, this is a great campaign, and any education is better than none because by and large, the average Joe does not know well enough any signs, kind of when to be concerned about the symptoms that they have. If I had a nickel for every time I've had patients in rehab who have had a stroke say to me, they're recounting their story, because I always ask them what happened. And they're recounting their story, and there's some version of it of where something happened. They had some weird symptoms. Maybe their arm went completely numb, but they thought they just slept on it weird, so they let it be for a couple of days. Some strokes can come on really slowly. And let it be for a couple of days. Their arm literally lost all feeling for like 3 days before it progressed, and then they came to the emergency room. If I had a nickel for stories like that, I would have paid off my student loans by now. It's crazy. People don't know enough about this type of thing to know when there's room for concern. Anyways, ultimately, strokes have to be diagnosed with radiographic evidence. Then the two main ways that we do this is through CT scan and MRI. A lot of times patients will have both CT and MRI, both have their own pros and cons. CTs are great for kind of that quick and dirty, in and out, acute, emergent, we need some imaging of this brain yesterday. It has some limitations though, in the sense that the picture is a little bit more grainy when compared to MRIs. You do miss out on certain presentations and tissue involvement. So an ischemic event, for example, so if you were to have a ischemic stroke, will not show up on a CT for the first 6 to 12 hours. So a CT scan will completely miss an acute stroke. CT is great for individuals that get claustrophobic and maybe can't tolerate an MRI. Anyone that has a metal implant can't go in an MRI, so that makes it easy there, but it can miss some things. The other big thing about CT scans is that you see a lot of shadowing when you get closer to the bottom or the base of the skull. And so lower cortical and then also kind of brain stems and cerebellar regions are not well displayed on CT. We won't be able to see anything well at all. Then you have your MRIs. MRIs will definitely help you with more acute ischemic events, but they're costly, they're longer, they can be really overwhelming for patients. You can't go in if you've had a metal device. MRIs have size limitations, so morbidly obese patients cannot fit into MRIs. MRIs will either be typically a T1 versus T2. I know you guys haven't been fully oriented to this terminology yet. This is just your introduction. So the pictures are there on the side. And really the only difference between a T1 and a T2 is how they structure the image so that you can see certain tissues better. And really it just kind of flip-flops what is white and what is not. And what is gray and what is black, it looks very different. So these are the exact same structures, one being a T1, one being a T2. So you could see that if you're looking for something specific in a specific type of tissue, one image might be better than the other. So that's sort of where we will maybe make a decision one versus the other, but ultimately both can be very helpful. Angiography is another way that we can go further into confirming the presence of a stroke. You inject, it's invasive, so typically we will rely on the CT or the MRI first, and angiography will just give us further information should we need it. Angiography is where you inject dye, usually in your neck too, and then shoot it all the way up and kind of see what goes on with that blood flow. The dye follows the blood through the arteries. We're taking an image the entire time, and it picks up on that dye and it lights up like fireworks, and we can see, you've probably seen pictures of it, but you can see it follow along kind of like a snake in a tunnel, if you will. And if there is an area of hemorrhage, that dye will flow right out into that hemorrhage, and you'll see kind of looks like a big cloud. If there's a blockage, that dye will start short. So that can kind of show us very specifically where the insult is happening. It can be helpful for surgical decisions, things like that. EEG and SPECT scans are for seizures. You guys are familiar with EEGs. SPECTs show us, can be additional information on if we're seeing post-ictal or interictal symptoms with seizures, and then also can be really helpful with identifying the specific location of where a seizure is coming from. These guys are added into our radiographic evidence for strokes because seizures are often a common sequelae of certain types of strokes. So oftentimes this will be part of the battery. PET scans, I know you guys have at least heard of them before. Those are generally used more for research purposes, but you may see them involved. It looks at how the brain how our brain works through its own glucose levels, how much energy it is using. And usually you will see increased areas around an area of insult. But typically, just because they're super involved, super expensive, super specific machinery, that's more on a research side of things. Here's a really nice graphic. This is just a basic introduction to diagnostic imaging. You guys have a whole course on this, but this is just a really nice chart that I refer to plenty about when a CT versus an MRI might be preferred and kind of what each one might be looking for. Obviously, I'm not the one, you're not the one ordering this or ultimately making the decision of what image needs to be done. That is done by the medical team. Where this actually can just be really helpful in terms of learning this chart is you may have multiple radiographic images and pictures taken, and this just kind of knowing what you're looking for in terms of what you're reviewing prior to going in, you can narrow down which ones you actually want to look for, because some of these will tell you something and others won't. That's usually how I use this. Okay, and then when someone comes into the emergency room and we call a code stroke, we have concern that a stroke event is either happened or is going on right now. There's a couple of different things that we can do. Number one is we can just watch it. There's a lot of reasons why we might not touch anyone and just monitor a stroke, maybe make some slight medication add-ons or adjustments if there's a lot of comorbidities, if we, have any significant barriers or contraindications to any of the interventions I'm going to talk about in a second. We may just need to watch them. If we don't think it's going to be serious enough to warrant any invasive measures, that's great. We may just watch them, those kind of things. The biggest thing that you're hoping for when you have an ischemic event is that this patient's going to be a candidate for TPA. TPA is that clot buster that you guys heard about. It is an incredibly helpful drug when available and when a patient meets the criteria for it. And the two main criteria for TPA is that it has to be ischemic. This is a blood thinner. Its job is to go in and break apart or bust open that clot that is causing this ischemic event. It's supposed to get in there quick and hopefully salvage some of that tissue that is at risk for dying. We don't get that tissue back. And it can be very successful. TPA is very highly correlated with prognostic return for any neurological return after this event. Huge differences in functional recovery for someone that has TPA versus someone that doesn't, but it has to be ischemic. If you were to give someone who's having a hemorrhagic event TPA, it's going to make the hemorrhage worse. They'll probably die. It's very dangerous. Has to be ischemic. We have to have clear, definitive radiographic evidence that an ischemic event is going on. The other important thing to know about TPAs is a very small window. And really, so right now, it kind of depends on the hospital and the state. I've seen variability all over the place. The most average one you'll see is like 4.5 hours. If we can get to this patient within 4.5 hours of the onset of their stroke, so the first sign or symptom, whatever that might be, we're going to give them TPA. More research in the last year or so is pushing for 9 and seeing if, I don't know why 9 versus 8, don't ask me, but the 9 hours is what I guess current research is striving for to see if we can still have the potential benefits. It's thought after that window that the benefits are too little too late. And so it's not worth adding something like a blood thinner into someone's system, that's because there's of course any risk with any injection of anything, but blood thinners can cause problems if not needed or if given out of sorts. But it's kind of thought after that point, it's not worth it. It's too late. That brain tissue's gone. For our hemorrhagic CVAs, there is a particular intervention that we may see called coiling. Coiling and clipping, but coiling is more common. And basically what that is, it's an arthroscopic. They go in and the surgeon winds his way up to the area of infarct or of hemorrhaging, along the way, he's bringing a coil with him. Think of it like a little coil. It can be a variety of different materials, copper, metal, platinum, you name it. Don't ask me why one material would be used the other. That is way beyond my level of knowledge. But the coil's job, they'll put this little itty bitty coil right at the area where that hemorrhage or that aneurysm is underway. And it blocks that area to stop and reduce the excessive blood flow and unnatural blood flow out of that artery wall. And it does so in 2 ways. One, the actual coil itself blocks it. It's a physical barrier. But then what it also does with a little bit of time is that foreign object, our body doesn't like foreign objects. And so our body responds to that coil by forming clots and plaque around it to try to kind of, almost like if I cover up the problem, I won't know about it, is kind of the way that I see it. But it actually, that coil encourages more plaque formation and clotting formation around that area to further close up the area of the arterial wall that was damaged. So that's coiling. You'll see that a lot. And then the other 2 guys are craniotomies and craniectomies. Craniotomies are where they burr a hole into the side of the brain and they suck out any blood that's going on. And then craniectomy, you're also going in there to evacuate excessive blood and swelling, but craniectomies are for more severe brain injuries and strokes when the swelling is so bad that it's concerned that the swelling is going to cause its own further damage. Our skull is super hard. It's a protective case for our very fragile brain. Our skull does not expand or contract. It is one size fits this brain. So after any type, it doesn't have to be hemorrhagic. Hemorrhagic, it's more common, but you can have edema, secondary edema from an ischemic event, anything that causes additional swelling in the brain, whether it's blood pouring out of an artery during a hemorrhage, or secondary ischemia secondary edema from ischemia, or a combination of either, there's nowhere for it to go. And so what it ends up doing is it pushes on healthy brain tissue, and that healthy brain tissue dies, and we don't want that. So we've got to get that swelling down, and sometimes a craniotomy is not going to cut it. So what a craniectomy is they actually go in and they take the part of the skull out. That part of our skull stays out for a while. It can be weeks, it can be months, it kind of depends on the patient and the doctor and the case. It's going to let the swelling, what you'll kind of see with these folks is you'll actually see the swelling come out a little bit. It's a little alarming to see for the first time. And then eventually that swelling will come right back down. And eventually they will return that skull back onto the head. While someone is waiting for that, it's called a cranioplasty when they put the skull back on. While we're waiting for the cranioplasty, these guys have an open part of their brain that is not protected by the skull. Now, you can't see their brain. They staple it up, it's just skin. But it's still very vulnerable. These folks have to wear helmets anytime they're out of bed just in case they fall, and if they were to hit their head, that would be probably devastating and fatal. So those are kind of our major acute managements in terms of interventions. There's a couple of other ones that you may see here or there, and like I said, sometimes patients will just be simply monitored, but those are kind of our big boys. Okay, we're going to pause here. When we come back, we're going to start talking about some common clinical features of CVA in general. I'll see you there.